You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about percutaneous coronary intervention. In this episode, I will cover aspects of revascularization by PCI from the perspective of the generalist. I will focus on much deeper aspects of PCI from the perspective of the interventionalist in a separate series, including topics such as bifurcation stent strategies and radiation safety. All of that will be beyond the scope of the general cardiology board exam. So let's start with access and informed consent. When conducting informed consent on patients about risk of cardiac catheterization, be sure to distinguish between the risk of a diagnostic left heart cath versus the risk of a PCI. The risk of death is approximately 0.2% in a diagnostic cath and 0.65% in a PCI without STEMI. The risk of MI is 0.5% in a diagnostic cath and less than 2% in a PCI. Risk of stroke is 0.07% in a diagnostic cath and 0.17% in a PCI. The risk of major vascular complications is 1% in diagnostic cath and 1.4% in PCI. The risk of serious ventricular arrhythmia is 0.5% in both. Radial access has lower bleeding risk and all-cause mortality than femoral access. For patients on warfarin, INR should be less than 1.8 for femoral artery access and less than 2.2 for radial artery access, although this varies by institutional practice. If the femoral puncture site is above the inguinal ligament, it may be difficult to establish hemostasis with manual compression. If the femoral puncture site is below the bifurcation of the femoral artery to the superficial femoral and deep femoral branches, then there is increased risk of formation of pseudoaneurysm after sheath removal. What does the 2021 AHA-ACC SKY guideline for coronary artery revascularization say about access site? In patients with ACS undergoing PCI, a radial approach is indicated in preference to a femoral approach to reduce the risk of death, vascular complications, or bleeding. That's a Class 1 recommendation. In patients with SIHD, now renamed chronic coronary disease, undergoing PCI, the radial approach is recommended to reduce access site bleeding and vascular complications, Class 1. Now, for the very important question of when to PCI. The first medical contact to PCI time should be within 90 minutes, especially for a STEMI. The ED to PCI time should be within 30 minutes. Primary PCI for STEMI has a Class 1 indication within 12 hours of symptom onset to improve survival, a Class 2A indication if it's 12 to 24 hours of symptom onset, and a Class 2A indication if it's more than 24 hours if there is ongoing ischemia, CHF, or dysrhythmia. This is similar to the classification of indications for fibrinolysis as opposed to primary PCI for STEMI. After 24 hours, if there is no ischemia, CHF, then PCI for STEMI should not be performed. That's a Class 3 recommendation. The benefits of PCI performed more than 12 hours from symptom onset are diminished. However, in patients with cardiogenic shock, there is a reduction in mortality seen at both 6 and 12 months in those who are revascularized within 26 hours of the onset of the MI, according to the SHOCK trial. Therefore, PCI should be performed in STEMI patients who are in cardiogenic shock or acute severe heart failure, regardless of the time of delay from MI onset. PCI is indicated over TPA even in patients at high bleeding risk who present with STEMI as long as it's within 12 hours of symptom onset. Medical therapy for high bleeding risk patients who present with STEMI could be considered if they are presenting more than 12 hours after symptom onset and hemodynamically stable, or if there was a severe active bleed. Compared to fibrinolysis for STEMI, primary PCI for STEMI leads to a lower rate of death at 7% compared to 9%, reinfarction at 3% compared to 9%, ischemic stroke at 1% compared to 2%, and hemorrhagic stroke at 0.05% compared to 1%, as well as shorter hospital stays and lower follow-up costs. These percents are in STEMI revascularized by primary PCI versus STEMI revascularized by fibrinolysis. And note that these are different from the earlier set of numbers I presented to you of the rate of adverse effects in left heart catheterization. That was for patients who are presenting in anything other than STEMI. Okay. Compared to fibrinolysis for STEMI, primary PCI of STEMI does lead to a higher rate of vessel patency at 95% compared to 54%. So that's a good thing. The safety and success in establishing reperfusion from PCI from primary STEMI is more than 90%. All around, primary PCI beats fibrinolysis in STEMI, basically in every category. What does the 2021 AHA-ACC SKY guideline for coronary artery revascularization say about revascularization of the infarct artery in STEMI? In patients with STEMI and ischemic symptoms for less than 12 hours, PCI should be performed to improve survival. That's a class 1 recommendation. In patients with STEMI who are stable and presenting 12 to 24 hours after symptom onset, PCI is reasonable to improve clinical outcomes. That's a class 2A recommendation. In patients with STEMI complicated by ongoing ischemia, acute severe heart failure, or life threatening arrhythmia, PCI can be beneficial to improve clinical outcomes irrespective of time of delay from MI onset, class 2A. In patients with STEMI and cardiogenic shock or hemodynamic instability, PCI or CABG, when PCI is not feasible, is indicated to improve survival irrespective of the time delay from MI onset. So far, we've seen that the situations where you can proceed with PCI for STEMI that's beyond the 12 or 24-hour window is if they have cardiogenic shock or hemodynamic instability, or they have acute severe heart failure, ongoing ischemia, or life-threatening arrhythmia. In those patients, even after 24 hours, you're still allowed to proceed with PCI. In patients with STEMI, in whom PCI is not feasible or successful, with a large area of myocardium at risk, emergency or urgent CABG can be effective as a reperfusion modality to improve clinical symptoms, class 2A. In patients with STEMI who have mechanical complications, such as ventricular septal rupture, mitral valve insufficiency because of papillary muscle infarction or rupture, or free wall rupture, CABG is recommended at the time of surgery with the goal of improving survival, class 1. In patients with STEMI, emergency CABG should not be performed after failed primary PCI in the absence of ischemia or a large area of myocardium at risk, or if surgical revascularization is not feasible because of a no reflow state or poor distal targets, class 3 harm. In asymptomatic stable patients with STEMI who have a totally occluded infarct artery more than 24 hours after symptom onset and are without evidence of severe ischemia, PCI should not be performed. Class 3, no benefit. Now, we talked about when to PCI in this section. Now, let's talk about whether to PCI. Half of STEMI patients are found to have multi-vessel disease. Left main coronary artery stenosis is considered significant at 50% stenosis or higher, but all other arteries require 70% or higher stenosis to be considered significant. FFR or IFR is recommended to guide the decision to proceed to PCI in patients with stable IHD, undocumented ischemia, i.e., they have not had a stress test, and angiographically intermediate stenosis. That's a class 1A recommendation for FFR or IFR. Note that this is for stable ischemic heart disease, not for ACS. Coronary stenosis in the intermediate range can be clarified by adjunctive technologies. The intermediate range is defined as 40% to 70%, but some other sources define it very widely from 30% to 90%. FFR that is 0.80 or lower supports doing PCI. IFR that is 0.89 or lower supports doing PCI. Somehow I just remembered that 4 is 8. That's why FFR, the cutoff is 0.80 or lower. And then IFR is like, sounds like IT9. IFR. So 89 is the cutoff for IFR. Intermediate IFR lesions that are 0.90 to 0.93, just above the 0.89 cutoff, those should also be investigated by FFR with intravenous adenosine or intracoronary adenosine if you have that intermediate IFR of 0.90 to 0.93. An IVUS determined minimal luminal area of less than 0.6 millimeters square also supports doing PCI. Although PCI in stable CAD no longer has any indication for improving survival, PCI in stable CAD is still indicated for refractory angina despite GDMT with coronary artery stenosis that are significant and amenable to revascularization. That is a class 1 indication. What does the 2021 ACC/AHA SKY guideline for coronary artery revascularization say about revascularization of the non-infarct artery and STEMI? In selected hemodynamically stable patients with STEMI and multivessel disease, after successful primary PCI, staged PCI of a significant non-infarct artery stenosis is recommended to reduce the risk of death or MI. That's a class 1 recommendation. In selected patients with STEMI with complex multivessel non-infarct artery disease, after successful primary PCI, elective CABG is reasonable to reduce the risk of cardiac events, class 2A. In select hemodynamically stable patients with STEMI and low complexity multivessel disease, PCI of a non-infarct artery stenosis may be considered at the time of primary PCI to reduce cardiac event rates, class 2B. In patients with STEMI complicated by cardiogenic shock, routine PCI of a non-infarct artery at the time of primary PCI should not be performed because of the higher risk of death or renal failure, class 3 harm. Now, what do the 2021 guidelines for coronary artery revascularization say about revascularization in NSTEMI as opposed to STEMI? In patients with NSTACS, which is the updated term for NSTEMI, who are at elevated risk of recurrent ischemic events and are appropriate candidates for revascularization, an invasive strategy with the intent to proceed to revascularization is indicated to reduce cardiovascular events. That's a class 1 indication. In patients with NSTE-ACS and cardiogenic shock who are appropriate candidates for revascularization, emergency revascularization is recommended to reduce risk of death, class 1. In appropriate patients with NSTE elevation, ACS who have refractory angina or hemodynamic or electrical instability, an immediate invasive strategy with intent to perform revascularization is indicated to improve outcomes, class 1. In patients with NSTA-ACS who are initially stabilized and are at high risk of clinical events, it is reasonable to choose an early invasive strategy within 24 hours over a delayed invasive strategy to improve outcomes, class 2A. In patients with NSTA-ACS who are initially stabilized and are at intermediate or low risk of clinical events, an invasive strategy with intent to perform revascularization is reasonable before hospital discharge to improve outcomes, class 2A. Two more. In patients with NSTE-ACS who have failed PCI and have ongoing ischemia, hemodynamic compromise, or threatened occlusion of an artery with substantial myocardium at risk who are appropriate candidates for CABG, emergency CABG is reasonable, class 2A. In patients with NSTE-ACS who present in cardiogenic shock, routine multivessel PCI of non-culprit lesions in the same setting should not be performed, class 3 harm. Now, let's talk a few details about the PCI itself. Routine aspiration thrombectomy prior to PCI was initially thought to be beneficial, but larger scale studies later showed no benefit in cardiovascular death, recurrent MI, stent thrombosis, or target vessel revascularization. In fact, there was increased stroke rate. Therefore, as of the 2015 guidelines, routine aspiration thrombectomy is not recommended. In the 2021 ACC/AHA SKY guideline for coronary artery revascularization, it says, in patients with STEMI, routine aspiration thrombectomy before primary PCI is not useful. Class 3, no benefit. There is no significant increase in coronary dissection with aspiration thrombectomy, though. Because a drug-eluting stent impairs endothelial growth after balloon expansion, extended use of DAFT is required after stent implantation to prevent thrombosis. The first generation drug-eluting stents had more thrombosis than a bare metal stents, but second generation drug-eluting stents have lower or equal stent thrombosis compared to bare metal stents. So now there's really no reason to use bare metal stents. Bare metal stents have a risk of restenosis requiring repeat revascularization. Although there are hundreds of stent types, only 3 main stents are used commonly in the United States. Boston Scientific Synergy, which is made of platinum, chromium, and elutes everolimus. Abbott Science, which is made of cobalt, chromium, and elutes everolimus. And Medtronic's Resolute Onyx, which is made of cobalt, chromium, and elutes zotarolimus. No reflow phenomenon is suboptimal myocardial perfusion despite restoration of a lumen patency in the infarct-related artery, i.e., despite stent deployment, the flow through the artery remains slow and intravascular ultrasound shows no problems. No reflow phenomenon can be from atheroembolization causing microvascular obstruction, vasospasm, myocyte reperfusion injury, inflammation, endothelial injury, or edema. There is no treatment or prevention. It is associated with higher mortality, reinfarction, cardiogenic shock, and heart failure. What if you got to do PCI in a patient with prior CABG? Let's see what the 2021 AHA-ACC SKY guideline for coronary artery revascularization says about PCI in a patient with prior CABG. In patients with previous CABG with a patent lima to the LAD who need repeat revascularization, if PCI is possible, it is reasonable to choose PCI over CABG, Class 2A recommendation. In patients with previous CABG and refractory angina on GDMT that is attributable to left LAD disease, it is reasonable to choose CABG over PCI when an internal mammary artery, IMA, can be used as a conduit to the LAD. Class 2A. In patients with previous CABG and complex CAD, it may be reasonable to choose CABG over PCI when an IMA can be used as a conduit to the LAD, Class 2B. What does the guideline say about PCI for SVG disease, saphenous venous graft disease? In patients with previous CABG, if PCI of a disease-native coronary artery is feasible, then it is reasonable to choose PCI of the native coronary artery over PCI of the severely diseased SVG. That's a Class 2A recommendation. In patients with a chronic occlusion of a SVG, percutaneous revascularization of the SVG should not be performed. Class 3, no benefit. In select patients with previous CABG undergoing PCI of an SVG, the use of an embolic protection device, when technically feasible, is reasonable to decrease the risk of distal embolization, Class 2A. Now we'll touch upon a little about ISR, in-stent restenosis. In-stent restenosis occurs due to local proliferation of neointimal tissue. Factors that increase rates of restenosis include small vessels, long lesions, the presence of diabetes, and mechanical stent issues, including underexpansion. 15% of PCIs in the United States each year are performed for ISR. The optimal treatment for ISR is debated. If there is a single layer of prior stent, the ISR can be treated with ballooning and placement of a second layer of drug-eluting stent. A recently approved approach is the use of drug-coated balloons without new stent insertion. Recurrent ISR with multiple layers of stent is treated with coronary brachytherapy with beta radiation to impede the proliferative process. That's what I have for you for percutaneous coronary intervention from a generalist perspective. If you are going to be taking the interventional cardiology boards, there will be a separate series that delves into each specific topic within PCI. But this should be good enough for now.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.